All right, take two because we already recorded that we technically effed this up already, and we went through the whole presentation by accident. Well, I think we recorded this. This is depression in geriatric patients. It's me, Kevin, Nate, and Corlin. Uh, so for us, our population is geriatric population, which this is older adults, age 65 and plus primarily. Vulnerable population include people who are at a higher risk of poor health and are often associated with social problems, which can include not having friends around as much. So for economic problems with increase in healthcare and increase in everything, they don't have as much money because they're not working usually at this age. Politics, which is a political factor. As we see with elections, there's a lot of people fighting, and grandma and grandpa can get very upset during that time. Um, as environmental factors, depression in an older adult usually refers to a persistent experience of persistent sadness, loss of interest, and a range of emotions and physical symptoms that affect age 65 and older. And these type of depressions can include major depression disorder, persistent depression disorder, seasonal affective disorder, and premenstrual dysphoric disorder. This population has many risk factors for depression, which can include age-related changes as they get older. They have more health challenges, which we see with patients getting COPD or other illnesses. There's social isolation. They're not able to go outside and see people as they once were, or like COVID. We had a high rise in depression throughout, but also in this population, as a loss of independence. When they start being restricted of what they're able to do, whether it be drive or other things, it can lead to a person having prolonged sadness or depression. Older adults can have unique factors for depression, including chronic illness, as I said before, COPD, or they'll get hypertension and other comorbidities that lead to issues. They'll have a cognitive decline, which can be Alzheimer's or other disorders, which lead to poor health outcomes or masking kind of the depression, which they do have. A loss of loved ones, which can be their spouse, their daughter, even grandchildren, which can lead to depression in these type of populations. Social isolations, as I said before, during COVID-19 are just not being able to get outside as much. Financial hardships, they're not able to cover as much of their bills or their medical bills even, and this can lead to a big burden on them, which sometimes it leads to depression. There's fear of dying in the unknown. As you get older, you don't really know what's going to happen after you die, and this can lead to a lot of stress and not knowing kind of what the next step is. And then retirement can kind of take away you from being able to do what you love, whether it be working, other things inside of it. And it'll kind of, you don't know what you're really going to be doing, and you just sit at home, and it can lead to a lot of depression. Medications can also cause depression, which we're going to learn about later. This can cause a effect that instead of treating it, it'll cause more depression, even, and other medications will just cause depression as a side effect. Depression in older adults is under-recognized heavily, and it is misdiagnosed because these symptoms can be masked. We see this in Alzheimer's patients where they'll have a cognitive decline, and it'll be looked at as a normal aging process, and it really will be they're depressed, and it can kind of make the onset of another disorder kind of even worse. This vulnerable population requires special attention to ensure appropriate diagnosis, treatment, and support. As I said, a lot of stuff goes under the radar, and this can lead to very bad outcomes. Left untreated, depression in older adults can lead to worsened physical health, a decreased quality of life, and increased risk of suicide, which we see this in older adults where they'll just kind of commit suicide and it'll be because they had other problems going on and people didn't realize they were depressed at the time. It was some other illness that they had. Therefore, it is critical to address both the physiological, or psychological and social factors that contribute to depression in older adults and their overall well-being. So the scope of depression in geriatrics, I use the major America's Health Rankings 2024, and they said in New Jersey alone, there's a value of 12.9% of adults that are at the age of 65 or older that have a mental illness, mental health profession tell them they have either major depression, minor depression, depression, or dysthymia, and this is the ninth highest out of 50 states. The overall percentage of adults 65 and older that are affected by depression is 15.5%. Depression also has economics attached to it with $326.2 billion being used for depression alone in the United States. Worldwide depression is the leading cause of disability, and up to 50% of cases go undiagnosed in the elderly population. And worldwide, pooled prevalence of depression in the elderly population is very high. It's at 31.74%. So even though it's better than the US and worldwide, it's still a major contributing factor worldwide.
Some of the physical presentation of depression is the patient may appear sad or sometimes ill. Depression affects their eating habits. They may eat more or less. They have an unconfident posture. They might slouch. They won't pay attention. They won't make any eye contact. Their body movements are slowed, and they also have anxious movements, and they might play with their hands or their hair or like anything in that range. Their mood and affect, the client may seem helpless, hopeless, or anxious, and they may say that they're a burden or a failure in life. Um, they become easily frustrated or angered at situations, and they typically will sit alone and may be seen staring or daydreaming. Some of the DSM-5 diagnostic criteria for major depressive disorder is five of more of the following symptoms have been present during the same 2-week period and represent a change from the previous functioning. At least one of these symptoms is either a depressed mood or a loss of interest or pleasure. The symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. The episode is not attributable to the direct physiological effects of a substance or another medical condition. The occurrence of the major depressive episode is not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or other specified and unspecific schizophrenia spectrum, and other psychotic disorders. And there has never been a manic or hypomanic episode. The symptoms that there need to be 5 or more present consist of a depressed mood most of the day, nearly every day, as indicated by either the subject report or observations made by others. So anyone can report this, not just the patient themselves. A markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Significant weight loss when not dieting, or weight gain or decrease in or increase in appetite nearly every day. As I said, there's a change in their appetite with this. They might eat more or less. There is insomnia or hypersomnia nearly every day, psychomotor agitation or retardation nearly every day, fatigue or loss of energy nearly every day, feelings of worthlessness or excessive or inappropriate guilt nearly every day, diminished ability to think or concentrate or indecisiveness nearly every day, and recurrent thoughts of death, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. So pharmacological treatments are the first line of treatment for anyone with major depressive disorders. The dosing and medications is dependent on the patient's response to the prescribed dose. And these medications can be cyclic antidepressants, MAOIs, SSRIs, and atypical antidepressants. And then there's also alternative treatments such as ECT, psychotherapy, other somatic treatments such as TMS, magnetic seizure therapy, deep brain stimulation, and vagal nerve stimulation. Electroconvulsive therapy is used to treat depression in select cases, specifically when a patient is unresponsive to antidepressants or experience intolerable side effects from medication at a therapeutic level. And this is especially true to the older adult population.
So some of the barriers to care, a stigma around mental health is probably one of the biggest barriers to care. One study found that 75% of females and 40% of males reported being embarrassed to ask for help with their mental health. Cost is another one. Older adults who saw cost as a barrier to mental health showed a higher prevalence of depression and symptoms than those that did not. And then direct and indirect cost of care are very high, and public investment is very low in the mental health area. So even in high income countries, making it hard for people to get the care that they need. Transportation for the older population is also one of the stigmas and barriers. Lack of availability to transportation can have a negative impact on older adults, and just not having many older people don't drive and they may have mobility problems, so walking to their appointments and stuff can be difficult. And then gap in knowledge for healthcare providers. Like we mentioned before, many older adults can present with symptoms of like mental decline, like dementia, but it could just be like underlying depression. So screening for depression needs to increase for that. And then some resources. Primary care providers can screen older adults for depression and make referrals to geriatric psychiatrists or social groups. And then Medicare will cover therapy and services provided by qualified primary care providers and community health workers. And then psychotherapy and psychopharmacological therapies are available for older adults to treat depression, with psychotherapy, support groups, and CBT being probably the leading ways to treat this. And improving social connections is critical for treating depression in older adults.
So when it comes to nursing implications, one of the main things we want to do is recognize it immediately on assessment. This is because depression is typically underdiagnosed in the older population due to the misconception that it is a normal part of aging. So some of the symptoms we previously spoke about that we should note is sadness, fatigue, irritability, and especially isolation from others. We should also utilize the Geriatric Depression Scale, or the GDS scale, which has two different versions of it. There's a 30-question form, which is the longer form, and then there's the short form, which is 15 questions. And it's a questionnaire with yes or no questions, avoiding complex answers. So some of this type of questions that it'll ask are you satisfied with your life? Do you feel that your life is empty? Do you often feel helpless? And even, do you prefer to stay at home rather than going out? Typically, the score will determine whether it is actually depression that this patient is dealing with or not dealing with. Another thing that nurses will do is holistic care approach. So we really want to consider all aspects of this patient's health, because it could be different things that are triggering depression, such as a social aspect where maybe the patient's family member, someone close to them, passed away. An emotional aspect, how are they dealing with that person passing? Physical aspects of their health. So things like this are medication side effects. A lot of the time, geriatric patients do have a lot more medical issues, which leads to polypharm. So maybe there is some type of medication that is causing this depression. And especially isolation. We want to monitor for isolation. We want to collaborate with other healthcare providers, such as social workers and psychiatrists. This is really going to help us overall with the patient, in the sense of maybe there's something going on at home or not that is better managed by other people other than just nurses. And then we really want to focus on a patient-centered care. So we want to educate patients on signs of depression and their families with the signs of depression, and what are some treatment options. We really do want to also establish a relationship and rapport with the patient, because without having that rapport, maybe the patient isn't going to talk to us as freely. So we really want to establish that so they talk to us. And lastly, strategies to improve access and care. Because we talked about previously that transportation can be an issue, we do want to utilize telehealth services. This is going to help get over that barrier. We can do this by providing simple teaching to the patient about electronic use and make appointments for meetings and ensure the internet is usable. We should really have family involved in this so they are getting the care they need. And we want to implement community-based mental health services. This will help get over the barrier of the stigma, because a lot of these older patients have that stigma that we previously talked about. By recommending senior centers and community organizations to provide free and low-cost depression screenings, we can help these patients get into a community where they are able to meet people like them and understand that depression isn't something to be upset or afraid about. It's something that they can embrace and really work through.
And then these are all our references. And that is the end of the slideshow. Hope you guys have a good break. Have a great break, Dr. Gioka. I know you're away, so you won't be there for a fun test on Thursday.